everybody. Welcome to the first roundtable discussion hosted by ALTIUS Healthcare Consulting Group. The goal of these roundtables are to give you weekly updates given the current crisis environment that we are in. We have several panelists today from different spectrums of the healthcare environment, so we are excited to have you all here.
As many of you are aware, we had anticipated beginning roundtable conversations on specific disciplines beginning in either April or May. And the goal of those were to really have Altius come to the table to share information on specific disciplines such as pharmacy, radiology, nursing, finance, revenue cycle, and other disciplines to really provide our clients with additional information that are specific to those areas and dive a little bit deeper, as well as allowing our managers and our clients to network with each other, share information, and ask questions. As we were really watching the COVID-19 and coronavirus situation unfold before our eyes, as all of us are doing right now, we found a need for us to actually end up doing this earlier. So we've launched these roundtables this week to begin, and we're going to hold these weekly. The roundtables will be recorded and saved into our client portal so that all of our current clients can access information, and they will be sent out to all of the clients or former clients that actually register for the presentation and the roundtable. So if you find the information useful, we'd really enjoy it if you would continue to participate. We're going to change our content each week to meet your needs. So the content will be based off of the questions that you have, the information that you're looking for, and ultimately down the road, it will be a roundtable discussion as well, so you can all network with each other and support one another as we move forward with this. Today, I'm joined by 5 panelists in different areas of expertise. We're going to be hearing from Joni Tiller, who is a clinical consultant from Altius, as she focuses on interim executive placements as well as nursing. We will hear from Michael Evans from Revenue Cycle Solutions, who also does a lot of strategic planning work and leadership. Josh Vierling, who is going to talk to us from Parathon on Revenue Cycle Truth podcast, as well as what he's seeing his clients do right now in regards to revenue cycle and what steps they're taking currently to move forward. We're going to hear from Pete Stille on supply chain and things that your organization can do right now to be prepared there. And then Aneel Irfan from the telehealth perspective of what healthcare organizations are doing today to prepare for the changes in telehealth that have actually accelerated quite a lot. We've been hearing from clients that did not really have telehealth even in their spectrum before this started. And now they're moving forward with really ultimate speed to make sure that they're able to address the Medicare population and others. So with that, we're going to get started and talk just a little bit about where we are currently in the framework. So there are new normals that are existing everywhere. We've been talking to a lot of clients this week. I've spent a lot of my time on the phone with strategy sessions, and if there's anything that your particular facility wants to discuss, please reach out. We're doing that as a courtesy to everyone in the industry right now. What we know is that there's going to be no back to normal for healthcare. What we knew 2 weeks ago, 3 weeks ago is not going to ever be the situation that we're operating in again, because we've learned so much from what we've already experienced. And we know that right now we are moving on to the fact that the clear and present priorities on how to handle this crisis is what everyone is focusing on. But as we're doing this as an industry, we're uncovering the issues that we need to address. So the next time that we're faced with a potential pandemic, we can respond in a little bit clearer fashion. Some of these things that have really forced us is moving a lot of our workforce remotely so that the workforce that does not need to be within the doors of a hospital can work remotely. We're seeing a lot more social networking and roundtables like Altius is doing currently for our current and former clients. There are task forces that are coming together that are addressing rapid changes, where we see forces like Google and Epic coming together and working with Intermountain Healthcare. We see other task forces within the federal government that are being addressed daily. And this is going to really change the environment that all of us work with on a day-to-day basis. There's a lot more AI happening with innovative care models. We're moving to top of licensed clinical practices because we have to. It's no longer a luxury to have RNs performing non-RN essential duties. We see providers that have to make sure that they're operating there. So rapid change. Payment reimbursement concessions are happening, and we're just moving at a very rapid rate. So what we've been hearing are a lot of concerns across the country from our clients. And really, everyone is in a bunch of different spectrums. We're working with clients that are in Atlanta, for example, where they're already at peak capacity and their ICUs currently do not have any additional beds. So their issues are a lot different than clients that we have in rural Indiana, which right now are figuring out how they can deal with the fact that they're down 35% in their elective procedures, and they have to figure out what to do with the staffing that they have during the downtime, but prepare for the situation if the virus does in fact hit them. So what we're seeing are elective procedures and volumes being canceled across the country. This is causing severe financial issues temporarily, maybe permanently. We know that there was a package that made it through the Senate last night and will be going to the House and then ultimately to signature that will release funds into the hospitals for crisis interventions. But what we know is we need to make payroll in between. So how do we address that situation and how do we actually deal with that while we wait for those funds to actually reach the hospitals? We also are seeing that the losses on treatments from COVID-19 patients are ranging from anywhere to $1,000 per patient to upwards of $2,800 per patient. And it depends on what part of the country you're in and what your reimbursement structure looks like. But that's what we're currently hearing from our clients is they're projecting that range of between maybe losing $1,000 per patient to maybe $2,800 per patient. So the question is, how do you continue to operate and provide the highest possible quality of care to the patients that you serve and make sure you're also able to balance the financial piece? And that's what we're really focusing with our clients right now. One of the things that we see happening throughout the country, overtime costs are going up and call costs are also causing concern. There's a lack of cash in some facilities just to cover the expenses for supplies right now that are starting to infiltrate and where you're running out of those, or even just getting supplies in has a higher cost today than it did 1 month ago. We're seeing the expectation to increase demand without necessarily the finances to do so. We've had clients call us because they've been asked to increase their demand by 50%, and just having the discussions of where do we put the beds? How do we convert single rooms into double rooms for non-essential patients? What do we do to make sure we're able to put pop-up tents outside? So all of those conversations are occurring, and while we're doing that, there's higher costs of supplies and a rate of change in areas like telemedicine that we've never seen before in our history. So what strategies are we hearing from our clients that they're currently tapping into right now? Number one, we've seen clients that have started to tap into term loans, either short-term or long-term, and really reaching out to their bond markets, their lenders, to renegotiate and or restructure their bonds where they have the capability. They're tapping into line of credits where they see that as a potential. And in some cases, we've been asked to help provide them with staffing models and some financial staffing guidelines that deal with how they can tap into those loans. So it really helps you to gain that financial flexibility during the uncertain times and uncertainty. We've also seen a lot of decisions by clients to change from some of their capital expenditures, where maybe they were looking at large investments this year, they're putting those off until next year or delaying them until we gain a little bit more certainty into the climate. One of the things we know is happening across the country, we've all heard it all over on the news, elective procedures are being canceled at an alarming rate and non-essential services. We've also heard, and Joni's going to speak a little bit more about this, is a lot of hospitals are currently canceling nurse contracts and in temporary areas. So these would be your contract nurses that are there in places where they don't feel they're going to need them in the short term, so that they can actually engage in getting contracts for other ICU nurses and or training their own staff. And we're also seeing a reduction of hours in non-essential staff hitting the marketplace. So what strategies do we see happening and what have we started to help guide our clients on the staffing side of the business? Number one, hospitals are starting to call upon retired nurses and clinicians where possible to take shifts because they are short-staffed in certain areas of the country. So if you're already in the group of hospitals that are experiencing that influx, this is a way that you can provide a little bit of bandwidth into your hospitals. We're also seeing specialist areas such as clinics, OBs, GYNs that are asked to start to train and or understand what's happening in the ED and or ICU. So the special areas now that have been downsized or they've been canceled because of unelective surgeries being taken off, now they're in a situation where they're being asked to support. So this is something we're working with our clients on, of finding those pockets of staff within your organization that you haven't tapped in before that you can reassign. We also see medical students that are being given the go-ahead early to start practicing, and our orientation schedules being ramped up and accelerated right now so that they can move into the nursing role or move into the clinician role faster and support if and when the COVID-19 crisis reaches their hospital. And we're seeing facilities within healthcare that have recently closed that are quickly being reopened, as well as facilities that have been shuttered across the country for years being reopened to really take some of that influx of patients if the physical structure is able to actually ramp up and be safe and provide those additional beds for organizations. So we're having a computer that's acting up, so we're going to go off script here. So with the latest productivity reports, the one thing that we need for our hospitals to do is within the productivity component of things, we really want you to look at your latest productivity reports or any benchmarking reports that you have, whether they're from Altius or not, and use that information to identify where you may have the ability to reassign resources. Looking at skill mix of nurses that you have throughout the organization that are available, looking for management people that might be able to come back and provide support so that you can kind of create a pool and plans in case you need to act upon them of where those resources are. We're also asking our clients to really prepare for potential impacts and worst case scenarios by dividing out teams, possibly A teams, B teams, C teams that will rotate through with rotating schedules if in fact you reach that crisis point. We're also saying that there might be the preparation for potential compensation of healthcare professionals. And we know that if they actually contract the disease, they're going to be out of the rotation. So what do you do if in fact you have someone that moves out of that rotation? And most importantly right now, how do you make sure that your staff is trained on all the areas that they might need to assist in, whether it's respiratory, the ICU, or simply transporting patients? How do you make sure they're prepared during this downtime that you might have? And number one, make sure that they're rested and ready to go. So those are the immediate steps that we're actually working with our clients to take right now. So steps that people have taken, and again, these aren't necessarily things that you want to do, but they're things that we've heard that have happened across the country, is we've seen furloughs of hospital employees that fall into the non-essential staff. And if they're not in direct patient care, they're not directly impacted, you don't need them right now for your day-to-day operations. We've seen those individuals furloughed and allowed to work from home in order to comply with some of the shelter-in-place regulations. We've also seen a lot of charge master employees and other coding employees and revenue, finance, HR, et cetera, moved into the remote home environment. On either the roundtable next week or the week following, we will be talking about some security things and issues. Just as a point of reference, we do have a client recently that had a situation arise from someone working remotely from a security perspective, where they were actually hacked by ransomware temporarily. They got out of the situation quickly, but I do want to raise that to everyone's attention that as you move into those remote environments, make sure you have the proper security protocol, and we'll be addressing that on a future conversation. So work to strengthen your provider capacity, ensure that the physicians and providers are working at the top of their license, identify personnel across the board that you can cross-train, and Joni's going to talk to us a little bit more about that in a second, and then identify licensed personnel within the facility in non-clinical roles that may be able to temporarily treat patients. These might be managers that have moved up and they're now serving in mostly management roles that could be pulled back into service if necessary. They might be individuals that move from the bedside RN over to a coding role that, again, if they're still licensed, they can be pulled back into service immediately. So all of those areas that you think you might be able to pull resources, change their duties temporarily so that they can support the hospital, you want to start to work looking at those areas. A few other things that you can look at as you work through is start to really focus in on some of the areas that you might want to look at as you're moving forward with maybe looking at hiring a manager or executive to really staff a command control center. And this really is focused in on areas where you know the projections are all showing that you're going to be hit pretty hard in the upcoming weeks, days. We've had facilities that have hired someone, they've brought retired executives out of retirement to do this. They've also brought retired nurse managers out of retirement to do this. But just placing someone in charge of your staffing pool or someone in charge of your crisis emergency preparedness, so they're the point person that any questions go directly to them, can help to really alleviate some of the stress on the rest of the organization. So these duties include leading the team, ensuring locations are properly, effectively, and expeditiously staffed, and then also addressing any changes that your organization needs as the pandemic changes in your locality. So this is something we've seen organizations do because it helps with that response. They can actually become sort of the spokesperson as well for your emergency preparedness and take that weight off of the rest of the executives. And we've seen that work really well in certain hospitals and healthcare systems. We have also had hospitals that have started to revisit their budget, whether they're on a budget cycle where right now it's March and you're looking at July 1 as your next fiscal year, or whether you're a January 1st start date and you're 3 months in now and you know that your budget for 2020 is already blown. They're revisiting that budget and aggressively addressing it and identifying areas that need to change so that they can properly be positioned for the future. And this is supplies, telehealth, everything that you didn't anticipate, you need to look at and adjust right now. And if you're on a July 1 cycle, there are a lot of steps that you can take to make sure you can still complete your budget in time, even in the midst of this crisis occurring. We also have had communities that really looked at eliminating some non-essential service lines right now and taking that entire staff and repurposing them currently to support in other areas. So there are a lot of creative things that are occurring. Each state's a little bit different with license requirements. So make sure you visit what they're doing under this Emergency Act before you actually do anything. And with that, I'm going to actually allow Joni Tiller to share a little bit of what she's been hearing within the industry from the nursing side of things. Joni is a former chief nursing officer, and she's also been a bedside nurse for years. And so, Joni, I'm going to turn it over to you and let you share a little bit of what you've heard from colleagues in the industry and some steps that you think hospitals should take moving forward.
Thank you. Thank you very much. I'm glad to be here. I appreciate the invite. I think the key word that we're all thinking is that this is very unprecedented. There's not a book that we can all go to that tells you how to manage this situation. There's been a lot of command centers put together, disaster planning drills, but I don't know that anybody effectively created a plan for when you have a pandemic. We all knew it was coming, but that's the piece that's been a little bit strange for everyone. As far as the tertiary hospitals, what I'm hearing from them is that they are opening positions for temporary positions for critical care and also for the emergency room, and in addition for screening, because they're trying to keep the patients, in all honesty, from coming in the ED door. And when they're screening them outside, they're also trying to help them understand you need to go home and you need to confine yourself or isolate yourself from others. The big issue is having enough testing kits. That's been a big issue with the screening. And so I know there's frustration with the medical staff and nursing staff regarding access to the screening tools that are needed. But the tertiary hospitals, if we listen to the news, CNN and different ones, that's what's going on, you would think, oh my God, all the hospitals are like at max capacity. What was it, New York? We even heard that Governor Cuomo said that he has mandated all of his hospitals to go 50% additional census on top of what they have. Now, if I'm the CNO in that hospital, I'm going, oh my God, I have no idea how to manage 50% more. And so they're really stretched to their maximum and being asked to do more. And the only way you can do more without additional staff is you're asking the nurses to be stressed and the physicians to be stressed even more by taking more patients than what they feel safe. So what I'm hearing a lot from the tertiary hospitals, the nurses are exhausted, they're scared, they're afraid for themselves getting the COVID-19, and they're also afraid taking it home to their families. So you've got a staff that's at capacity, that's stressed, that's also afraid of getting it and sharing it with their family. Interesting enough, social media, it really is very telling. And so there is a group that's called the Gypsy Travel Nurses, and they're very outspoken. I get tickled by them because they tell you exactly what they're thinking, and you just have to take it with a grain of salt. But what I'm hearing, there was over 700 at the time that I took a look at what was going on, over 700 responses. And what I was hearing completely caught me off guard, to be honest. And they were talking about how their hospitals have a low census and how people are being called off. And, you're not hearing that in the news. We're only hearing about the hospitals that are overwhelmed. But there is a very large portion of, and I suspect, community, rural, critical access hospitals whose volume is not where we're talking about. They're not even hitting their budgeted perspective. And so these nurses are being pulled off. And what I worry about when I hear that is that when you keep calling nurses off, and they have to, I mean, they're counting on that money to support their household. Many are single spouses, or just it takes both spouses to fund what they're trying to do. But what your risk is that you're going to lose them, and they're going to get into travel agency because there is a demand nationally and they're willing to travel to get it. So I really want to emphasize the importance of maintaining a good relationship with your current staff. And so if you're experiencing a low census, make sure that you are communicating and educating and keeping them involved in what the plan is and what the strategy is. I add to that the important part is also stay connected. And I actually believe your CNOs are already doing this, but I'm just throwing it out there. Stay very connected to the state boards of nursing and also the state hospital associations, because they know what the state strategy is. And if the state strategy is to try and get all your patients diverted to your tertiary hospitals, your trauma hospitals, the 1,000-bed plus, then that helps you then strategize on how you're going to manage in your community. And so for your community, it may be screening, it may be the telehealth, and I think that's on the agenda. It may be urgent care, instead of them coming into the hospital, ways that you can do that. But the CNOs, if that is the strategy in their state, should contact the city, and it could be 30 miles away, not very far, but they should be contacting the tertiary hospitals and saying, how can we partner? What can we do to help you? Because it may be that your nurses are willing to go to one of the larger hospitals and do 3 or 4 shifts in a row, and somebody provide housing. I know a lot of hotels are providing housing for healthcare workers, but let them go to the city, work there full time, and then come home. And I say that because just saying, we don't need you today, go home, one, doesn't really make them feel good. It hurts them financially, and also it harms the relationship they have with that hospital. And remember, prior to all this happening, we had a nursing shortage. People like to deny it, but it was out there. Right now, the shortage is critical care nurses and emergency room nurses. So in addition to what I just talked about, I highly recommend you also take this opportunity to cross-train your staff. And there's a lot of online programs that the nurses can do, so that then when they come in to do their clinical, they can learn the equipment, the drips, the medications, working in an ICU situation. But now is a great time to take your med-surg nurses and maybe your PACU nurses, because your PACU nurses typically are ACLS certified and critical care certified. So it's a great time to take them and cross-train them and let them work in the ICUs. Some of the articles I was reading was that the ICU nurses are actually saying, we are desperate, we are exhausted, and we understand that nurses from the med-surg areas or IMC areas may not have the skill set for critical care, but we are dying for help, and we would love for you to come help us. So that's another compliment that you can do, is they can go to the unit and they can do a lot of, probably 80% of the nursing care that's needed. They may not be able to do some of the critical care required expertise, but the critical care nurses are so tired that they're willing to work collaboratively. So what I'm highlighting is that you may be considering a different model than what we historically have done. We've always been very black and white. You're either critical care or you're not. You can't work in critical care. Today, the model may be an ICU nurse and a med-surg nurse cohorting or working together with these patients. The other thing I highlight is that it's important that where the patients are being located, that you have negative pressure. And my experience in community hospitals and rural hospitals is that usually there's maybe 1 or 2 negative pressure rooms, or maybe there's 4, but there's not an abundance of negative pressure rooms. So it's not a matter of, oh, we can take all these patients. You have to look at your facility and what you can manage. But typically what you are going to do, and infection control nurses or disease can help you with this, is that you want to cohort those patients. You don't want 1 or 2 per room throughout the hospital. You really want to put them all together in certain areas for maximum efficiency. For the nurses that are caring for the patients, donning and doffing is what they call it, the personal protective equipment, is very time consuming and it's exhausting. And so when the nurses are in caring for the patients, they're all geared up and they've got everything proper. But if there's something missing, they have to take everything off, go out and get it and reuse the equipment. So it's really important that we recognize that it's more time intensive when you have more patients that are in isolation. As far as the time that the nurses are in the room. I would add to that that the personal protective equipment probably is one of the hottest issues with nursing right now. It is hot, and nurses are afraid, like I said earlier, of getting the disease themselves or sharing it with their families. But they are running out of personal protective equipment, and now they're being told, there's a lot of folks in the community, which we appreciate, don't get me wrong, that are trying to make homemade masks. And the advantage of having the homemade mask is that if they do it right, if they design it right, they can insert a filter, supposedly, that helps. Now, here's the conflict for your nursing population. The American Nurse Association has come out most recently with a statement saying, we do not support using homemade masks. And so the nurse who's been trained to do what their license says and what the American Nurse Association says is now being told, we're out, use this homemade mask. Now, granted, that's better than nothing. I totally get it. But they're in conflict and they're afraid of getting the COVID-19. So that's the other thing I just want to highlight, is having the right equipment is critical right now. In addition, there's hospitals that are paying combat pay, is what they're referencing it as. A lot of discussion going on nationally with the nurses about that. Interesting enough, I get a kick out of this when I'm reading it, is that some of your baby boomer nurses are highly offended that any nurse would ever say, I want additional pay for taking care of these patients. And it's not only the baby boomers, there's a blend, but they seem to be the ones that are really making a statement. But they're seeing Walmart is getting bonuses, they're seeing Amazon's getting bonuses, all these people are getting bonuses for working, and the nurses are, some of the nurses are saying, we're not getting anything and we're being asked to do more with less. So there's also that frustration going on. I'm not recommending additional pay, but I am seeing that that is a hot topic nationally. What I am seeing the trend to be is the ones that are doing it seem to be paying $150 per $150 per shift. So roughly, if you're doing 6 to 7 shifts, it works out to be $1,000 bonus. So that's one issue that's out there. Combat pay is what they're calling it. The other thing is the nurse to patient ratio. Typically, you'll see critical care is 1 to 1, 1 to 2, depending on the acuity of the patient. Your INC is 1 to 3, 1 to 4, depending on the acuity of the patient and where you are, rural hospital versus tertiary hospital. And then your med surg, typically you'll see 1 to 6 and 7, sometimes 1 to 5, but it depends on your patient population. What I'm seeing going on right now with the COVID-19 is that the nurse to patient ratio for ICU remains the same. There's no change there, and INC remains the same. But the med surg, what we're reading is, and this is in the city, they are saying 1 to 3, which is really catching us off guard. So 1 to 3 is the nurse to patient ratio. And the reason they're saying that is because they're finding is that your support services, housekeeping is, this is just what I'm reading. I'm not saying it's applicable to your facility, but housekeeping is refusing to go in the room. They're afraid to get the disease. Dietary won't go in and deliver the trays or assist with fooding. Even some hospitals are saying that respiratory therapy won't go in the rooms, which I find hard to believe because usually they're just like the nurse, they're very comfortable in the situation. But they're finding their support staff is not willing to go in the room. So more and more of those support responsibilities are being put on the nurse. Not that they mind, but it's more difficult to take care of a larger volume of patients when you're having to provide the respiratory treatments, innovation, that kind of stuff. So that's the staffing ratios. And then I would end with my recommendations being the number one thing, and gosh, it's been there forever, and that is communication is key. The staff need to know what you're planning, what you're thinking, what's going on, what the issues are. They need to know what the strategy is. And so the concept of we'll just do our thing and let you know when you need to know isn't going to work today, because the more they feel included in what's going on, the more they're going to be there for you and support you. So communication is very key. Another highlight I just want to touch on is that we in nursing are aware that there has been an incidence of suicides among nurses, professional nurses across the nation. And we've seen that becoming more prominent, or maybe we have a stronger awareness. But I'm also reading that we're seeing nurses that have cared for COVID patients that have tested positive, that there has been incidents of suicide. And I don't need to be depressing, but I want to stress the importance of staying connected to your staff and hearing what they're saying and making sure that they have the support they need. And it might be employee assistance programs, or if you have a behavioral health service, they can be of great value to your staff. But they're not just worker bees. These are human beings that have feelings and a variety of issues that they're dealing with. And sometimes this one might be the one that tips them over. So I want to everyone to be aware of that sensitivity, that this is a very difficult time for the nurses. And so I think that's all I would add, Stephanie, unless anybody has any questions at this moment.
Thank you so much, Joni. I think those are exactly the types of things that everyone is looking to hear right now. And clearly the nursing spectrum is changing a lot with licensing and some of the other concerns, nurse to patient ratios. And I think touching upon some of the expectations for hospitals that aren't quite as far into the COVID-19 transition yet was really important. So really appreciate that. And this is a great time to really transition into another clinical area. Aneel Irfan is going to talk to us about what he's seeing with telehealth right now and some of the strategies that you can take to really push that forward quickly.
All right, guys, thank you so much. I mean, it was just amazing information. I'm so glad that you guys invited me onto the call today. So just a little background on myself. I've been in the telehealth and telemedicine space for 6-7+ years, very early in the industry, helping healthcare organizations not only with the technology, because technology is one thing, as we know, it's actually implementing telemedicine and virtual care solutions, and developing workflows and training, and the different aspects of telehealth, not just telemedicine, which is live audio video, and this is important to understand, but also store and forward, as well as remote patient monitoring. So it's amazing. It's critical to see what's going on now. It's really amazing to see what's going on now, that for many years we've been trying to show the value of telehealth and telemedicine and fight those regulatory barriers, which were around reimbursement, rural designations, and I'm going to talk a little bit about those as well. But to see them come down and really show and help on the front lines of healthcare right now, it's so critical to see. And so I'm here, and Stephanie was kind enough to invite me to give you some of those barriers that have been brought down, give you some good ideas of how to implement telemedicine and telehealth, not only for short term in the COVID pandemic, but also a long-term strategy, and also just answer any questions you may have in the immediate future. So I want to go over some of the recent updates, and Stephanie touched on them a little bit, but I want to break them down one by one. So again, like I mentioned, telehealth has had a lot of regulatory barriers, not only with commercial payers, but mostly around Medicare. How it used to be would be Medicare would reimburse for telehealth services, but they would only reimburse for rural designations and had originating site restrictions as well. So the first restriction that was dropped through recent bills over the last few weeks was that rural designations, making Medicare reimbursable for any beneficiary, no matter the location or geographic location. Also, they cleared up providers that could provide telehealth through Medicare. Before, it was a limited amount of providers, eligible providers. They've opened that up to nurses now as well, and other providers, and I'll provide you guys a list of those providers. One of the biggest issues also, and a real inflection point for telemedicine and telehealth, has always been crossing state lines, licensure, right? And so they have loosened restrictions on cross-state licensure as well. Now, these are waivers that may be maybe extinct and maybe just kind of a short-term play, but those restrictions have been loosened around practicing telemedicine across state lines. Another big aspect in regards to telemedicine has always been prescribing of controlled substances in the Ryan-Haight Act. So they have also loosened up restrictions in allowing providers to prescribe controlled substances via telemedicine. This was allowed in the past. In certain states, they had their own restrictions around it because it's one of the things that you have to deal with as well. Each state has their own telemedicine policies, but they've allowed it in regard. One of the restrictions have always been you had to have an in-person visit first, and so they've loosened considerably restrictions around prescribing controlled substances and scheduled narcotics via telemedicine. And one of the biggest ones that I'm seeing as well is loosening HIPAA compliance around video conferencing. So modalities that were not supported in the past, like FaceTime, Skype, are now eligible to be reimbursed and used. I do put a flag around that to say if you're going to prop up a telemedicine solution, make sure it is HIPAA compliant and encrypted. Especially in the long term, if you're going to have your telemedicine solution propped up, which most organizations will going forward, you should look for a true solution that is compliant and work with the vendor to get that HIPAA compliant certifications. Right now in emergency, I'm talking to providers every day. It is a godsend, and it really opens up for them to start and see patients right away using these not encrypted tools just such as FaceTime and Skype. But they know, and I'm telling them that from a long-term strategy, especially if you want that reimbursement down the road, you want to develop and use vendors that are HIPAA compliant, and there's many out there as well. And so I do want to touch upon the importance of these telemedicine solutions right now. Many of them are kind of no-brainers. We have to protect the safety of not only the patients, but also the healthcare workers, right? And what's happening is not only response to COVID, people that are worried about if they have COVID symptoms, but it's also people that have everyday regular things that they've already been working with, that already are dealing with, that they now need access to help to their doctors to address, because they're just fearful of going into the offices, right? And some hospitals are not even, like Stephanie touched on and the team touched on earlier, they're not even allowing patients in, and a lot of elective procedures are getting passed. So that's one of the biggest importance is you got to provide something in that touch point for your patients right now to access.
All right.
Also, this is a point of no return. You know, like Stephanie also mentioned earlier in the webinar, this is that point where we've changed healthcare forever. And so these virtual care solutions are being solidified. So it makes you start to right now think, I need to develop my virtual care strategy going forward. And my number one recommendation and strategy would be that you look at telemedicine, and virtual care is what I like to call it because it's the broader term. You think about the different modalities that not only have clinical use cases, but are recognized by payers to be reimbursed. And you start developing those virtual care service lines, so to say, right now. This is your trial period to get things, you get your footing, get budget, get a team together to develop a program. But think about the different modalities in virtual care that you need to start establishing. So I'm going to give you some examples. The most common is live audio video telemedicine. It's the most common. It's used. It's the most traditional thought process of the use case of telemedicine. The other one that is important to understand is store and forward, commonly used in teledermatology, radiology as well. basically an asynchronous solution, being able for patients to upload digital images for a review at a later time. So it's not a live solution. It's something that is an asynchronous solution where a provider is reviewing it at a later time, and that time can be billed and reimbursed of that provider's time reviewing that data. The third is remote patient monitoring, very commonly used in chronic care management, where you're actually providing medical devices in a tablet in the patient's home to monitor physiological parameters. Medicare release codes and other health plans have released codes where they are reimbursing for the actual equipment itself, monthly monitoring on the patient, and the 30 to 40 minutes spent each month reviewing that data. Very similar to chronic care management, if your groups are familiar with doing that. And so thinking about a strategy about how to prop up these different virtual care service lines are going to be critical as you go further after COVID, because these are going to be now proven solutions. People are going to be looking for them, and to supplement income potentially, and to proactively offer these solutions and streamline patient care. These are going to be important, very, very important to implement. So that's the bigger picture that I see, and that I want the healthcare leaders to also see. Think of the bigger picture after COVID. Now that virtual care is here and it's here to stay, think about how you can leverage it for better patient care and revenue down the road by establishing these service lines. So Stephanie, ran through that. I hope that's I covered all the important points that I felt like I needed to cover, but I really would like to open up for questions, because I want to hear the questions around virtual care and telehealth, because like you said, many organizations right now are just propping them up in lightning speed. It's, you know, so any questions you guys are having around that, please, I'd love to answer, and that's what I'm here for. Thank you, Stephanie and team.
Thank you so much, Aneel. So anyone that has questions, feel free to drop them in the chat. We're also going to share the contact information for all of our panelists after the call, so that if you want to reach out to them one-on-one and ask them any particular questions based off of what they shared, you can have their email address as well as phone information. So appreciate all the information. It's great information on telehealth. And I think as we evolve through this, we're going to see the remote access become something that's even more and more important for everyone as a community. It's actually going to help a lot of the community providers, especially in the rural areas, provide more services to the patients and communities that they serve. So it's a really exciting time in that regard. So with that, we're going to actually toss it over to Mike Evans. Mike is a principal of Revenue Cycle Solutions, and he focuses his practice really on two areas: strategic planning and strategy. So he does a lot of affiliation and merger work, as well as strategy discussions with healthcare organizations. And as a former CEO, he has a lot of experience with organizations that are on financial turnarounds and beyond. And he also focuses on revenue cycle solutions. So we're going to allow Mike to talk a little bit about the 3 to 5 things that he really believes healthcare organizations should be focused on right now as we move through this period of time.
Stephanie, I appreciate that. Let me mention a couple of things that I think are going to be very important rolling forward. First of all, the needs mentioned earlier are probably in this order: personnel, resources that are absolutely critical, and third is need for cash. And regarding need for cash, you mentioned it earlier, where elective surgeries, elective procedures are being reduced dramatically, in some instances 50 to 75%. And when you think about how hospitals have operated over the last number of years, their revenue has been driven more by outpatient volumes than by inpatient, to the point where outpatient revenues exceed 50% of total revenue. So when you see this kind of drop as quickly as we see it, the hospitals are going to need cash, and they're going to need it in a hurry. You combine that with the fact that most hospitals, particularly small and rural hospitals, have been operating on slim margins. So this is really going to stress them in terms of their ability to meet the needs. And then when you do have COVID patients, these are patients that have intensive use of resources, and they're very expensive. So again, that's going to be very taxing on the revenues and the cash flow of hospitals. Most hospitals don't have a war chest or a rainy day fund to sustain themselves through this unprecedented challenge that everyone is facing. And what we're really encouraging our clients to do is to make sure that their revenue cycle is operating at full throttle. Obviously, cash is king. They need cash flow very, very quickly. Thankfully, the government is going to step in with $100+ billion to help them kind of close the gap between the provision of services and reimbursement. They should be working with their insurers as much as they can to ensure quick cash flow. Obviously, you need to get bills out the door as quickly as you possibly can in order to have that cash flow continue. We're finding different ways for hospitals to register people remotely. The registration people are part of the frontline force that has to deal with these patients. And we're seeing a lot of folks do registration remotely and by phone. What we're also recommending is that there's going to be a need down the road for AR cleanup. There's going to be some backlogged AR that's going to need to be addressed, as well as having your processes operate very efficiently going forward. So these are a few things that immediately come to mind. I wouldn't be surprised if this whole episode drives insurance reform in some way, shape, or form, so that reimbursement can be speeded up, so that there's more cash to be had throughout a crisis like this. Again, this is very unprecedented. I don't have any doubts in my mind, speaking from a former hospital CEO position, that hospitals are going to be prepared to the best they can. They're going to do the best they can with the limited resources that they have. They do disaster planning on a very regular basis, and you're already seeing, particularly in New York City, heroic efforts by these folks, and this is what they're committed and trained to do. And there's no reason why, throughout all that effort, hospitals cannot reap the financial reimbursement that they are due in a crisis like this. And I'm very concerned that many hospitals going through this kind of challenge, particularly small and rural ones, this may be a death knell for them. So reimbursement from the government couldn't happen soon enough. I think insurers, I've not heard much about how the insurance industry is responding to this crisis, but I know that most are mandated by their state insurance commissioners to have resources in reserve for this very purpose, to handle catastrophic conditions. So I'm hoping that the insurers will step up their game and reimburse more quickly, maybe even advance some reimbursement to hospitals that are in need. I think, thankfully, right now for rural hospitals in Pennsylvania, there's the Rural Health Initiative, where they're being reimbursed in advance of care, so that there can be a steadier stream of cash flow. So obviously, these are very challenging times in many ways, particularly for frontline staff who have to treat the patients, but also for the hospital in general, who needs the cash flow to sustain itself during this crisis, as well as well beyond. So those are just a few comments, Stephanie, on how I think hospitals need to approach this particular situation. I'm very interested to see, in many ways, how New York City continues to handle the crisis there, because they right now are the epicenter. And the strategies that they put in place going forward, hopefully the rest of the country is paying attention, so that lessons can be learned from what's going on there. So those are just a few thoughts and comments relative to the financial troubles that hospitals are going to face at this time. I do think that, to the extent possible, they need to step up their game relative to making sure they capture as best as possible all the care that's rendered. I know many are working to establish new ICD-10 codes to capture everything that's to capture all the care that's being rendered, so that reimbursement can flow quickly and effectively. So those are just some thoughts that I'd leave with you, Stephanie.
Thank you, Mike. I think those are all really important strategies and things that hospital, executives, managers across the country need to be thinking about. And we all can be looking at New York City, as a guideline as to, watch how they're responding and learn from both the good and the, areas we'd like to improve. But there's some odd epicenters that I've heard of throughout the country in very small communities like Grand Rapids, Michigan, which is already starting to get stretched beyond, their seams and really struggling. And there's some other small rural areas across the country. So as this moves through, I think we're going to see all kinds of those areas, and the strategies that you provided will definitely help the executives. So Pete, take it away. Pete's going to share, what you need to be focused on right now with supply chain while we work to find Josh's mic and information.
Thank you, Stephanie. And piggybacking on Mike's comments, thank you to the clinicians out there who are on the front lines of this crisis. He mentioned heroic. Really, the sacrifice and the work you're doing truly is the definition of being a hero. Where would we be without you at this point? And also, thanks to the executives for these healthcare institutions who are leading during these very difficult times and providing courageous leadership with a lot of struggles and challenges in front of them. A little bit about me. I've been in supply chain for 28 years, and I see my role at this time. How can we best help you get through this as best that you can from a supply chain perspective and from a critical resource perspective? So as elsewhere, I can tell you from experience, your supply chain is under pressure right now, intense pressure as well. This is the biggest professional fear a lot of my buyer and materials manager clients have to run out of supplies and critical supplies that are needed. So they are working hard with some amazing challenges. The PPE crisis I want to spend some time on, because it really is front and center to a lot of the challenges to the safety of our healthcare providers and in treating our patients and getting this under control. And unfortunately, the market dynamics they could not be worse. We've got a fragmented market. We have a limited buying power. We have disjointed purchasing. We cannot forecast to be able to understand who needs what and when. There are parts of the country that are under directives from their states to have supplies in certain quantities ready to go when COVID hits them, and other parts of the country that are begging for them. So it's very disjointed, high demand, intense competition in the United States and worldwide. I think you guys saw the governor of Illinois was saying that he called the CEO of Medtronic and was trying to get respirators for his state, and he was advised to make the order now because the Chinese were trying to get a big order placed. And the governor of California chartered a plane to China to go pick up some supplies. So we are really in very strange times indeed. And but there is some guidance out there. And so I provided a little bit here. The CDC talks about things in terms of capacity and what to do. So we're way beyond the conventional capacity where things are proportionate, supply and demand. And many of us are going to contingency capacity. And this is where prioritization takes place. You realize you don't have enough supplies to meet demand, so you prioritize the supplies to go to the sick provider, the one most at risk of getting infected and having a negative outcome. You do not do the elective surgeries and save those masks. You do not give them to visitors or have visitors. But really, I wanted to spend some time on the crisis capacity part of this, because some of us are there and we all need to be planning for it. What happens if we don't have enough PPE, if we don't have enough cleaning supplies to practice safely and effectively? And this is what I call desperation, because at this level, you're really treating patients beyond US standards. and you're doing whatever you can. So some of the clients that I have, and some of the practices out there that are being discussed, I've given a couple of examples of here. And next week we can follow up more. The industry's coming together with a few different task forces that I'm going to be participating in the coming days, and I'll have some more information next week. But the first alternative that's talked about on the CDC guidelines page for this, as well as I'll give some perspective of what people are doing, is reusing PPE. So Nebraska Medicine, for example, worked with their infectious disease doctor to create a way to re-sterilize respirators. And they're doing that with UV lighting. They found that alcohol was not an effective way to do it, whereas you can use alcohol for their findings to clean face masks and reuse them. So there's that going on. There's also alternatives to PPE that are being investigated and have been used. In Italy, they actually went to a 3D printer and created an enhanced, quote unquote, enhanced scuba mask and distributed hundreds of thousands of those to healthcare providers. There are providers out there that are talking about using makeshift CPAP temps if they don't have anything else available. Providence in Washington has their volunteers that are sewing together materials to specifications to make them. And Johns Hopkins has some guidance out there. If you do need to turn to homemade devices, how to do that and how to do that safely. And then there is some other guidance on the CDC website that talks about what to do with no PPE at all that are out there as well. So really moving on, what should the next steps be in managing this crisis? So we can start with, obviously, on the next slide, establish contingency and crisis plans for shortages. We're all doing that. We definitely need to understand if there is a prioritization, what direction do you have to protect the supplies that you have from not going to essential workers, and making sure that they're available to the critical care nurses or those in those areas that are defined. Work with physicians to clarify specifications to see if there are additional things that you can do. Things such as headboards that can clean environments are being talked about. There's also some HEPA filtration fans that can be purchased. Come up with what makes sense for your organization, and begin a contingency plan for that now. And if you're already in that stage of crisis, it's the kitchen sink at this point. The other things available: re-sterilization, 3D printer sourcing. The buyers could get going to be engaging suppliers to see if they can help design some of this. And then what other sources you may be able to go to for homemade manufacturing. There's some businesses out there at a local level that are taking out the sewing kits and putting things together according to directives of how to do and provide this PPE equipment to healthcare organizations. In your local community, that could be something that could be helpful to develop those relationships and get those supplies close to home where needed. And then from a expense management perspective, there's a lot of contracts that are fixed fees. There's a lot of contracts with supply minimums. There's a lot of suppliers that will give you grace at this moment and should be thanked for that. By the same token, that there's some that may not, and there may be a misunderstanding. So we've talked with clients and advised them on different things in terms of reviewing the contracts. If it's got a force majeure clause, you could talk about for the time being, limiting the commitments that you have on your side while still purchasing those supplies at the price identified. And reevaluating that as the crisis comes to a better place. But also just even establishing a policy for organizations that your supply chain can take and put out there, or to accounting, to begin the conversation of, we don't need this amount of staffing right now in this area in dietary. We have this contract at a fixed fee of FTEs. We need to close the dining room. We need relief on that. And either doing that one by one or establishing a policy and protecting yourselves and communicating that to suppliers about how you're going to handle these things during this COVID-19 age. And then going forward, to kind of echo some sentiments that have been talked about already, finance should be charged with coming up with additional financial scenarios that can help return money to the bottom line. Some are in very critical situations. Some of the low change ideas out there can be implemented immediately. And this is a time where we're seeing a ramping up of assessments and identifying what additional financial relief and things that we're not doing that we can do, so we can position ourselves now to get cash in the door and when we emerge from this financial recovery. The last thing I wanted to mention is that for your organizations in the supply chain, if you have a membership to ARM, this is a subsidiary of the American Hospital Association. It's ahrmm.org. They have a webinar tomorrow, Friday, March 27th at 9 a.m. and they're sharing solutions that work. They also have a listserv if you do have a member in your organization that are sharing stories and asking each other about how to deal with some of the uncertainties and some of the fast changing things that are going on right now in the market. And I think that's all I had for you today. Look forward to talking with you next week.
Thank you, Pete. Great information, especially regarding some of the PPE concerns that our clients have voiced to us, as well as some of the steps that they can take right now financially. Everyone's looking at reviewing contracts and looking at areas that they can maybe build a little bit of margin right now just to get cash in the door. So great advice, and we look forward to hearing more about what you gather from the industry this week on next week's roundtable. That's a great transition into Josh Vierling and his work at Parathon. Josh is going to share some information on how to really get more out of your revenue cycle from revenue cycle updates. So he works in a similar space to Mike Evans as well, but more on the technical side and the technology side of things. So Josh, thank you for joining us on today's podcast and look forward to hearing what you have to say.
Okay. Hi, Stephanie. Can you hear me okay?
Yeah, you're good to go this time.
Okay, perfect. Thank you. Thank you very much for inviting me. This has been absolutely fascinating. This is a great venue. I really appreciated listening to all the perspectives. It's interesting. Yeah, so I'll give a little our perspective because we are on kind of the granular side of revenue recovery and revenue cycle right now, meaning we're working with clients day in, day out as this situation unfolds. So we're seeing a lot of very interesting things happen right now. It was also interesting to hear Mike's perspective because that kind of provided the executive perspective, which I find fascinating with what's going on. But as far as what's going on at the ground level right now with our clients, and we have over 100-something clients, we're starting to see certain volumes start to increase. We are starting to see an increased volumes. We're not in the heart of New York City, so we do have some facilities in New York that work with us, but not right in New York City. So I'm sure they're seeing more volume than we are, but we're starting to see a slight increase in volume. We are starting to see, though, everybody is preparing. So you are seeing revenue cycle and finance executives having to wear multiple hats. So some of them are handling registration. Some of them are handling kind of the oversight to what's going to be happening with the triage or the tents or things like that. So everybody's in full service right now, which is really good. IT is obviously being pushed. You mentioned this too, Stephanie, that projects may get pushed because IT is doing a lot of different things right now. Luckily at Parathon, we kind of are able to help facilitate some of the IT so we can offset some of that because we work with IT or we have access to be able to help them with certain IT initiatives. As it was said earlier by you guys, the surgeries are on hold. So what's interesting from my perspective, because we're doing revenue recovery throughout the country, is The surgeries are on hold, so that means revenue is going to be an issue, kind of like Mike was saying. Also, the payers, what we're seeing from the payers is pretty interesting, because a lot of them are dealing with what we're dealing with. They're going into quarantine right now, or they're having to kind of transition from a work in the office to a work at home environment. So wait times are going up, as we deal with different payers, which is interesting. We'll have to see how that pans out here in the future. Now we are getting through and business is getting done, which is great, but there has been certainly some disruption to the kind of the supply chain of payer provider relations a little bit now, given what's going on. Now that should smooth out, I assume, in a little bit, but why that becomes interesting is you have timely filing and you have things like that, which kind of affect your reimbursements. So that's a kind of interesting phenomenon we're seeing. Telehealth, as your guests have already talked about, is huge. I don't think I've been on a call today or yesterday where I haven't heard someone talk about telehealth. So everybody, when you talk about IT staff and revenue cycle executives kind of shifting what they're doing, a lot of them are involving themselves in telehealth, because telehealth is going to be really important moving forward now, and it's good to see that that's happening. And I have been on a few calls where revenue is starting to become, an issue. So this is an area where we specialize in, and we can help with some of the practical kind of services that can provide that. If you switch to the next slide, I'll kind of just touch on that really quick. So I think it's going to become more and more important here slowly. I think people right now are dealing with it. We're getting a few calls on clients that we're working with, but soon I think there's going to be a flux of a lot of calls where people are going to have to kind of look back at revenue. Certain services like zero balance services, ED triage and leveling services, and underpayment services are going to become more important, in my opinion. I think that's just going to happen. I think if you do have a backlog of denials, some of the current staff, the PFS and the business offices, are going to have to kind of focus on that backlog, which means certain things like zero balance and underpayments might get left, on the wayside a little bit, and you're going to have to kind of pick up the ball there. That's what I think how this thing plays out from a revenue, and a recovery standpoint. I think, expected reimbursements and variances, this is kind of the core of contract management, is going to become more and more important. I mean, the lifebloods of hospitals, in my opinion, are the contracts. Those are the lifeblood of the hospital. That's how they get paid. That's how they generate revenue. That's how they pay for their services. And that's how they make some money to pay for more services to help more people. And I think it's more important now than ever that those contractuals, those expected reimbursements, those variances are very, very kind of standardized, and people understand them very, very clearly. We talked about the IT capabilities. That's going to become more and more important. I think people are going to need to supply. We've told our clients we're there to help them. We transitioned overnight to an at-force workforce because we're in Illinois, and we have all the HIPAA and all. We've been doing this for 20, 25 years, so we had all the protocols in place to make that transition. Some people might not be as quick to do that, and I think they're going to have to involve certain companies that can help facilitate some of that. Billing is always going to be an issue, and it might be more of an issue now because some of these newer services, telehealth, some of the codes that we're seeing in the EDs, are a little different. There might be some opportunities there. So I think there's going to be a big emphasis on billing during that shift. So this is just some initial perspective. More data is coming in, but this is kind of what we're seeing right now. This is just kind of the way we see it laying out right now.
Thank you, Josh. Great information, definitely, especially in regard to the ED triaging and leveling and some of the underpayment components. We've been hearing that from some clients as well. And I also think the emphasis on accurate billing as everyone works to get the COVID-19 charge master up to date and make sure things are coded properly is really important, because sometimes we miss some of the things like the ventilators and some of the other supply chains, like Pete was mentioning. I think that's going to be an important component as everyone moves forward. So I appreciate everyone's participation. We do have a couple questions, or at least one question that came in from the participants, and Brian's going to manage those questions for us. And if anyone else has questions while the panelists are on the call, please feel free to drop those in the chat box and or reach out. And we do have contact information for everyone. As we mentioned, we're going to continue to do these weekly. They're not only going to exist during this crisis basis, but we'll continue them after that and move forward with our roundtables that we were going to do for our clients regardless. And this is just a great place for us to continue to provide support to all of you. As you know, your financial future and ours are very tightly aligned. And Altius and our partners that are on this call are really here to make sure that healthcare organizations throughout the country are really prepared for what's happening right now during this crisis component. We're also here to make sure that community hospitals remain open and to make sure that all of you continue to operate very financially efficiently. So with that, Brian, if we have the question from the panelists, we can move forward with that and then we can wrap up.
Yeah, we did have a question that was submitted that I will ask, and anybody on the panel, feel free to jump in with an answer here. Question submitted was, do you think we will see individuals that have or are receiving bills for past services not paying due to their concern with personal financial impacts, which would ultimately further impact your organization's revenue? And what are some ideas or tips to help weather that part of this storm?
Great question, and I think I'll let either Mike or Josh, pop in on that from a revenue cycle perspective if they'd like to take that, and then I can give my point at the end. See, Josh, you're open first. Let's let you go first, and then.
Okay, yeah, this is Josh. I think you can hear me, right? I think I'm on now.
We can?
Yeah, I think that's a great question. I would be interested to see what Mike says, but I absolutely see that being an issue. And there's some interesting technologies out there right now that help with payment plans, and I think those are going to come to the forefront right now when these situations have. But yeah, I think I read that unemployment rate is going up tremendously. So hopefully we get out of this thing and we see the exit plan and we start to get business back to normal. But I do think that will be an issue. And I do think what has to happen to make sure it's an ethical transition and hospitals work with people, they do have to leverage some of the newer technology platforms that help with kind of payment plans, help with knowing how much you own, and also help making it very clear as to what they're on the hook for and what the insurance is on the hook for, what the hospital's on the hook for. I think patient estimation cannot be an estimate at times like this. It has to be very, very clear, and it has to be based on the contractuals so people understand it. Thanks.
Thank you, Josh. And Mike, I'd like to get your perspective as well.
Yeah, I would agree completely with what Josh said. I think it's inevitable that this is going to happen because when you look at what's going on with the unemployment rate, millions of people across the country are unemployed right now. It's going to be difficult for them. They're worried about meeting their mortgage payments, their rental payments, car payments. And so, much like what typically happens, they put off paying their medical bills. So I think, as Josh said, working out some kind of a payment plan that's fair and equitable over a period of time is probably the best way to go to ensure that hospitals do recoup some revenue from the services that have been rendered.
Yeah, great points. And I'd add to that with one more component. Definitely unemployment rate probably going to come out of this at 30 to 40% once everything is said and done. We do know that with the stimulus package that was passed by the Senate on the table for the House and will eventually move through, there will be money coming back to the American public in some of the high-risk cases where the individuals probably do not have the ability to pay their medical bills, but that may not reach them until May or June. So right now, it's really getting those payment structures in place and helping your patients while you wait for those stimulus packages to catch up. And there's also the small business component of the bill that was just passed that will allow small businesses to actually get 2 months of operating expenses that will cover up to a certain limit of salary for those 2 months. So the goal is that small business will take those furloughed workers and actually put them back to work because now they're going to have this grant. And if they abide by the rules of the Small Business Association guidelines, that grant will then actually pay for those employees to be on salary during the next 2 months, which means that ultimately they'll have the same component. Now, it only goes up to a certain salary range, but that should help offset some of those issues with some of the patient population that you have coming through as well, as long as the majority of small businesses across the country actually apply for that grant and get people back to work fast. So the whole goal of the stimulus plan is to let's move past this as quickly as possible so that we do put the money in the hands of the Americans so that they can pay for some of those patient components. We also expect that the stimulus package that was just passed that begins to trickle through will actually get to the hospitals as well, and that will help. But absolutely make sure that you're looking at what your true cost is, having conversations with the patients, getting onto those payment plans and working through this, because it is going to increase. If they're in a high deductible plan and right now they're unable to pay the mortgage, ultimately they're not going to pay their medical bill in the short term. Are there any other questions from the panelists that came in, Brian, that we want to address right now?
No, that's all we have right now.
All right, well, thank you so much to all the panelists for participating. I think this was a great interaction from hearing from several sides of operations within hospital. To all of our client participants and former clients, if you have any topics that you would like to see on future roundtables, please reach out to anyone on the Altius team. You can respond to Josh, Megan, John, anyone that's sending out your biweekly reports. You can reach out to me directly, and I'll make sure that we queue all of those questions up, both by ensuring that we can answer those for you next week and the weeks to come, and also by identifying panelists can actually provide you to the answers to your questions. Also, if you're unaware, we have launched a podcast. Altius Answers has now been live for 4 weeks. You can find us on Spotify. You can find us on Anchor, Apple Podcasts. We're also on YouTube. And really what we're doing through the Altius Answers podcast series, addressing a lot of questions that our clients bring to us on a consistent basis. So you can actually access that for more information as well. And to everyone that's on the call today, thank you so much. And Altius is here for you to answer any of your staffing needs or requests. If you have questions regarding prospective staffing schedules that you need, or even how to just address the staffing that's happening with the pandemic, please reach out at any time. We're here to support you. So thank you much for joining our first roundtable, and we look forward to seeing you on future calls.
This virtual roundtable discussion was brought to you by ALTIUS Healthcare Consulting Group. For more information about anything you heard on today's roundtable, or to learn about services provided to hospitals and healthcare delivery systems by ALTIUS Healthcare Consulting Group, visit our webpage at www.altiushcg.com. To be able to get updates on future roundtable discussions, please send an email to info, that's INFO, at ALTIUSHCG.com, and let us know that you'd like to be added to our mailing list. Those on our mailing list will be the first to find out about future roundtable discussions. Thank you so much, and have a great day.